Good evening, everybody. I'd like to welcome you to tonight's General Practice Cancer Education webinar. Tonight's focus is on radiotherapy and supporting patients in their cancer treatment. Excuse a bit of a delay between the speech and the camera. We've got very bad weather where I am in the southwest and not very good reception, so we have got a bit of a delay. And I apologise for that. So my name is Dr. Louisa Case. I'm a rural GP by trade, and at present I'm the Director of Medical Services for the Goldfields Esperance area. And my substantive role is the clinical lead at Bunbury Hospital, which has a lot to do with haematology and outpatient cancer services and palliative care. Before we begin officially, I'd like to take a moment to acknowledge the traditional custodians and owners of the land on which we are gathered. Down here in the southwest, we pay our respects to the Noongar people and recognise their continuing connection to the land, waters and community. We also extend our respects to their elders, past, present and emerging, and acknowledge all Aboriginal peoples living and working in this area and joining us on our seminar tonight. Now, during the webinar, we'd love you to ask any questions you may have, but if we could possibly keep them till the end, that would be great. We'll address them during the Q&A session at the end, and to submit the questions, at the bottom of your Zoom, you'll see a Q&A function. And if you could please type them there, and then I'll address them with our speaker at the end. Finally, I'd really appreciate your feedback after the webinar. An online evaluation survey will just be sent out automatically, and we'd love you to complete it just so we can continue to improve the educational events that we provide for you, and we'd look forward to seeing you at more in the future. So tonight, I'd like you to welcome our special guest speaker, radiation oncologist, Dr. Eve Tiong. Dr. Tiong is a highly experienced radiation oncologist based at Icon Midland and Icon Rockingham. In terms of her background, she completed her medical degrees at the University of New South Wales and established her oncology career at Singapore's National Cancer Centre and the National University Hospital in 2009. She returned to New South Wales to continue her specialist training in radiation oncology at Liverpool Hospital in Sydney and the Canberra Hospital. And she was awarded fellowship to the Royal and New Zealand College of Radiologists in 2015. She then undertook a specialist fellowship at Princess Margaret Hospital in Toronto, Canada, where she further perfected her skills. So Dr. Tiong has training in advanced techniques, including stereotactic radiation therapy with intrafraction tracking, MRI simulation, and image-guided radiation therapy. I'd like to welcome Dr. Tiong to our screen now.
Hi, good evening, everyone. Thank you, Louisa, for the great introduction. I'm very flattered to be here this evening and to be able to, I guess, share my insights as a radiation oncologist, and hopefully we'll be able to answer some of your questions this evening. Now, I will work to share my screen. Bear with me while I get this working. Is my screen working?
So Eve, it's just showing
what about
your slides down the side. Yes, that's great. Thank you very much.
Perfect. Again, a lot of people don't know or may know that I'm actually also a Korean drama fanatic. So if there's anyone on the talk today who's also crazy over Korean dramas, we could definitely catch up over it. But for tonight, the talk is serious. We'll talk about how we can support our patients better in their cancer treatment from a radiation oncology perspective. These are the learning objectives to guide you through our decision-making process on how we select appropriate treatment for our patient. Not one size fits all. I will talk about what I would think that the most common side effects of radiotherapy is, the factors that influence the development, and how we could manage these common side effects together in the general practice, together in a specialist environment. But before we do that, I think it is important to understand radiation therapy, our terminologies, and our technologies. In Western Australia, the main method of radiation is delivered using a radiotherapy machine. This form of radiation is called external beam radiation therapy, EBRT. Stereotactic body radiation therapy, SBRT, is a form of external beam radiation therapy treatment that is ablative in nature. Brachytherapy is an invasive procedure, and it involves inserting radioactive sources directly into the organ of treatment. Gray and fractions, you hear us say all the time. Gray is the unit for our dose. For example, 78 gray, 60 gray. In 20 fractions, because we divide our treatment into multiple daily outpatient treatment in small doses or small fractions. Radiation works by damaging the DNA of the cells, and we manipulate their ability to reproduce. There is a difference in the ability to repair in normal and cancer cells. Cancer cells lack ability to repair these DNA damage, leading to cell death, whereas normal cells can repair and the side effects do recover. All of our normal tissues have a tolerance level or a maximum dose beyond which irreparable damage can occur. And when we do our radiation planning, we do take that into account. As I've mentioned before, external beam radiation therapy is non-invasive. The patients do not become radioactive. These are most often outpatient sessions, but inpatient radiation therapy can be delivered. And in the pediatric setting, radiotherapy can be delivered as an inpatient because they require general anesthesia, or if patients are unwell, elderly, and they are hospitalized, we can also facilitate inpatient treatments. This treatment can be used in the primary, neoadjuvant, adjuvant, and palliative setting in multiple cancer types, in multiple organ sites. So for example, well-established role in curing prostate and lung, as well as skin cancer. Well-established role level 1 evidence in adjuvant treatment for breast, prostate, and certain GI malignancies, and very effective tool for palliation to manage pain, skin fungation, and bleeding. You often see response rates up to 80%. There are 3 different machines that deliver external beam radiotherapy in Western Australia. The standard and widely available machine in both public and private setting is the LINAC, Linear Accelerator. We also are very privileged to have 2 CyberKnife machines in the whole country, one in public, one in private. This is going to change. And we have 1 MRI LINAC in Murdoch. All these machines are able to deliver advanced techniques such as stereotactic body radiation therapy. They all have minor technical differences and advantages. The last machine, Proton, is gaining a lot of popularity if your patients ask for it, but it is not yet available in Australia, and it's unlikely to come to Western Australia in the near future. These are the different type of machines delivering EBRT or SBRT. As you can see, all of them are external beam radiotherapy machines with different configurations and different technical advantages. I won't labor on this tonight. That could be a separate talk. Brachytherapy, insertion of radiotherapy sources directly into the organ. It has its own advantages, which I would describe hopefully a little bit later among my talk. Now, in terms of how do I make a treatment decision when I see a patient, I will focus on the concept of shared decision making. Nowadays, we practice personalized and tailored medicine. Not one cancer is the same and not one patient is the same. So we take into account patient, tumor, and treatment factors. And although it's 3 dot points, it's often much more complicated than that. We have to recognize there's a difference between doctor and patient's expertise or perceptions and priority. So often as an oncologist, we look at prioritized diagnosis, disease etiology, biology, prognosis. We discuss treatment options and the possible outcome probabilities, pros and cons of each option. From the patient's perspective, often this does take time for us to, reflect on, but you have to take into account the experience of illness so far. A lot of patients who I see has had what they call PTSD from their previous, cancer treatment, or from carrying their loved ones through previous cancer experience, social circumstance, attitude to risk. Everybody's attitude to risk is very different, what their values are, and this take into account their cultural beliefs and preference. So you can see this is a complex process, and therefore shared decision making is absolutely crucial. But as an oncologist, what helps us decide the paradigm of management is the stage of the cancer, whether this is early or advanced, stage 1, 2, or 4. Is this curable or not curable? What our aim is. We need to take into account age, fitness, and patient preferences about what they think about treatment options, and making sure that to the best we can, that patient understand all the facts. I find this a little bit challenging at my best of days. And often I find that it can take more than one consultation. And what does the treatment involve? Coming here every day, infusion, how does it revolve around school, pickup, drop off, work? What the benefits are, the downsides and side effects of treatment, and no matter what they choose, treatment impacts on their health. Now, I use the first case that I'd like to walk us through my patient, Mr. E.B. He's a recent patient, so he's fresh in my mind. He's 90 years old. ECOG, so we use the performance to describe performance status, an ECOG of 0, meaning that he's very fit, healthy, lives independently, loves gardening, still very sexually active, loves his life. He's an ex-smoker. He presented with a cough, and so therefore the routine investigations occurred. In the GP setting, it would start with a chest X-ray, which found an abnormal lesion in the right upper lobe, sent to specialist setting, and we conducted diagnostic and staging investigations with a CT scan and a PET scan. And as you can see, this PET scan showed a FDG, avid lesion in the left upper lobe that's been subsequently confirmed to be malignant. And there are no other metastatic disease, except that there is this incidental finding on his prostate. There is a focal uptake on his prostate as well in a 90-year-old man. What does this mean? An FDG lesion in the prostate could be inflammation, could be benign prostatic hyperplasia, but of course could be cancer. So all this going through our thought processes. Now, navigating treatment decisions in elderly patients is never easy. I just want you to know that my oldest patient is actually 101 years old. But we take into account their performance status, and the field of geriatric oncology is actually expanding, and there are all sorts of geriatric assessment scores out there to give us a guidance on whether we think the patient could cope with radical or aggressive or any treatment at all. There is such a thing called frailty index score that I personally use. We then have to look at their social situation, because they can have side effects. They may develop fatigue coming into multiple appointments. Are they able to report their toxicities? And long discussion about priorities. So with Mr. EB, I had a long discussion about quality of life versus quantity of life. The discussion revolved around, if we do nothing and just watch, would this cancer, lung, and possibly prostate cancer cause any imminent issues or imminently be life-threatening, versus quality of life? Is this cancer causing any symptoms currently? And if we deliver treatment, will the side effects of treatment outweigh the benefit of treatment? It's a very long discussion, weighing up the benefit of treatment versus risk, trying to predict a life expectancy in a 90-year-old patient is nearly impossible. Would he live to 100 or would he live to 95, given that he's so well, no other major comorbidities, anything could happen anytime. So shared decision-making is process, and this is where I take into account Mr. EB's priorities, what he wants, and what his risk attitude is, whether or not he would take the chance of the cancer progressing, possibly resulting in symptoms of cancer progression, which we could palliate, or giving treatment now and accept the risk of possible over-treatment. Mr. EB chose to have SBRT for his lung cancer. Now, it used to be that for radical treatment of early lung cancers, this used to be delivered continuously over 4 to 6 weeks. But SBRT means that we can shorten his course from 5 to 6 weeks to 4 to 5 short sessions, treatments over and done with within 1.5 weeks. It's one every alternate day. This particular technique is often designed for elderly and frail patients to begin with. So he actually chose to go ahead, and he tolerated radiotherapy treatment with no major adverse effects so far reported 3 months down the track. So now that he has completed his lung treatment, what do we do about the prostate cancer? Mr. EB, even though he is 90, he wishes to have all the information of his health. And of course, there are many of us out there who says, look, prostate cancer is not going to harm him. What is the point of investigating at 90 years old? I get it. If we didn't do a PET scan, we probably would never know about it, but we did a PET scan for his lung cancer. So can we ignore it? It's really up to the patient to weigh up whether or not he wanted the biopsy. It's important to counsel him about the risk, and he did. It confirmed Gleason 8 prostate adenocarcinoma, and for Gleason scoring, as you know, Gleason 8 indicates that this is a high-risk prostate cancer. In anyone younger, we would advocate for active treatment, but at 90, what are his options? Again, another 1 hour long. So Mr. EB took me 2 hours, 1 hour for his lung, 1 hour for his prostate, to talk about the options, nutting out. Look, Mr. EB, do we watch and wait? prostate cancer, the behavior is very different from lung cancer, longer natural history, unlikely to be life-threatening, watchful waiting. If you progress, we could give you treatment to prolong your life if that is what you wish. Treat the symptoms if the cancer progress. Or do you want treatment now to slow the cancer down, radiation versus androgen deprivation therapy, and then taking my time to talk about the radiotherapy side effects in detail, the androgen deprivation therapy side effects in detail, and giving him the option of going home to think about it. And Mr. EB chose watchful waiting. So this is the thought process going through our mind. And I guess my take-home message is when you see your patients after meeting a radiation oncologist, please do know that we do spend a lot of time going through their patient preferences, what their wishes are, going through the pros and cons of each option. I certainly hope that this has been your experience so far. Then conversely, the discussion is very different in a young patient. I saw a 49-year-old patient. He's a FIFO worker. He's married with 2 children, presented with PSA screen-detected prostate cancer, asymptomatic, sexually active, has favorable intermediate risk prostate cancer. Treatment will cure him. Risk is relapse. There are no comorbidities apart from obesity. He does have large abdominal girth and he is overweight. So he saw the urological surgeon and offered a surgical opinion. He is not suitable for a robot prostatectomy given his body habitus. So he's been offered an open radical prostatectomy procedure. What are his options? He was discussed in the multidisciplinary setting at Royal Perth Hospital. All these 3 options were given. Active surveillance, again, a discussion about the level 1 evidence on active surveillance, surgery, as well as radiotherapy, guiding him through the data, acknowledging that this is not imminently life-threatening. Active surveillance could allow him a period of weight loss, which may facilitate robot, but we all know that this is a very difficult journey and some patients find it really hard to lose weight. As I've said, surgery, you know what the implications are. He's had that very thorough discussion. And by the time he was referred to me, my job is to counsel him about all his options of external beam radiotherapy treatment, and that be external beam radiation and brachytherapy. In a young man, quantity of life is important, but quality is absolutely important. Because will live for a very long time with the possible late complications that can impact on their function. So navigating this decision for Mr. CM was not easy. It has been a life-changing diagnosis for him because he never expected to be diagnosed with prostate cancer at age 49. You would think and all assume that prostate cancer is a disease that affected older men only. This has affected his work and relationship because obviously having to take time off work for multiple appointments and investigations, causing financial strain and on his relationship as well. Again, long discussion of natural history of prostate cancer. Just to let you know, I actually treated his mother as well. So he does have, that experience of cancer within the family, really carefully weighing up the pros and cons of active treatment for him and really giving him a lot of time to think about that decision. Now, time. Some patients appreciate this time, but some patients don't. And it's really difficult to know who does and who don't. But I really think that they should have that time to really think through the decision, to minimize the decision regret down the track. And we often encourage support, such as PCFA nurse, counseling, and support groups. And in a young man, fertility and sexual health is very important to talk about. He is 49, but he actually has no children yet. And so which treatment and how does that impact on his, offsprings? Again, this decision cannot be made by the physician alone, nor by a multidisciplinary setting, because they can only give a recommendation. This is a shared decision-making model. So in terms of the side effects of radiotherapy, how does it impact on our patients? I categorize radiotherapy side effects into acute, anything that they experience during treatment and weeks to short months, really, and anything that occurs afterwards. And although their radiotherapy has completed, the onset of these toxicities can occur months to years after treatment. The acute side effects generally resolve, but the late side effects are permanent. But what I tell my patients nowadays is that the incidence of serious acute and late complications with modern techniques are not common. They're generally less than 5%. And it is, the late side effects, it is affected by the amount of radiotherapy given each day. So for example, in stereotactic body radiotherapy treatment, where we're giving a larger radiation dose each day, it does carry some slight increased risk of late complications, but because of our modern techniques, it is very, very safe to do so nowadays. In terms of acute reactions, the general side effect that most patients report is lethargy, tiredness. There are different subjective experiences. Some patients tell me that they could smell it, see it. I cannot explain it. There is no scientific evidence to that, but everything that the patient experiences on treatment can be subjective. Side effects are localized, confined within their treatment field, and it normally occurs in tissues that have a rapid turnover. So for example, in breast radiation, the patient might experience radiation dermatitis, or skin changes that develop gradually, swelling of the breast, which could cause some discomfort in the abdomen, common ones, nausea, vomiting, diarrhea, chest, shortness of breath, cough, esophagitis, if we are treating the lymph nodes. If the lesion is peripheral, then esophageal irritation is not an issue because there's unlikely to be radiotherapy dose there. Head and neck symptoms are very complex. Brain and prostate, the common symptoms are urinary and rectal symptoms. And late reactions generally occur in slowly proliferating tissues like lung, where they may develop fibrosis, kidney, cardiotoxicities in breast and lung cancer treatment, brain injury, radionecrosis after brain radiation, and the risk increases with the total dose of radiotherapy delivered and with the size of each treatment. Knowing that each of our organs has different sensitivity to radiotherapy and therefore different dose limit. So for example, our skin is very tolerant to radiation, so does have a higher dose limit compared to our spinal cord, for example. And how do we know? I guess in the olden days, my very esteemed colleagues have conducted these studies in mice to get a sense of it. In terms of managing common side effects, now I've chosen to talk about fatigue because I think fatigue is very prevalent in all cancer patients, young and old, affecting patients that has had either chemo or no chemo, radiation. And in radiation patients, it generally peaks 3 to 4 days, and then it usually improves after they finish treatment, but it can also persist. If it persists after radiotherapy, it is often accompanied by other symptoms and signs like depression or shortness of breath. And we really need to assess it depending on their diagnosis. What types of treatment did they have, whether or not it's with chemotherapy, Did I treat the lung and the stage of disease? Does this patient have stage 4 disease? Obviously, the more advanced the cancer, the more likely they are to be fatigued because their baseline reserve is low. And it's often multifactorial. You can't just attribute fatigue to radiation alone. Often there is a combination of age, comorbidities, medications, chemotherapy, androgen deprivation therapy. And I say to my patients that if they are still feeling fatigued months after completion of adjuvant treatment, then really we need to screen for other reversible causes of fatigue. And to assess that, it's very challenging, going over again the onset pattern and duration. And I find that sometimes patients themselves don't really give an accurate account of when their fatigue really starts. It's difficult to know exactly when this starts. It's probably a gradual start rather than an immediate one. And the change over time, and to try and find out whether there's other factors associated with it. Are they sleeping? Are they worried? Are they depressed? Are they eating and drinking? Are there any other social stressors around? What their cancer treatment history is, psychological evaluation, social considerations. As we all know, all this interplay. The general strategies. So when my patients come to my clinic and they tell me that they are fatigued, I emphasize a lot on physical activity, and we discuss the various exercise programs that are available. Now, when I say various exercise programs, I'll talk about it a little bit more. Often there are catered ones for prostate cancer, breast cancer, as well as from the Cancer Council. But other than that, it is motivating patients to find an exercise regime that suits them. Energy conservation, setting really realistic expectations. I have 80-year-olds who used to do 1 acre of farming. After the cancer treatment, they're really depressed because they can no longer do that. So it's really setting their realistic expectations. And my mentor in Canada says that the quality of life is subjective and it depends on what expectations you set on yourself. So it's get to help the patient understand that their body is undergoing significant change and they are not going to be able to do what they used to do a year or two ago. And even if they want to do that, they need to slowly get back there and pace themselves accordingly. And it's going to require effort. Then to review the list of medications that could contribute, whether or not they're on any excessive opiates, whether or not they are diabetic, and rule out other causes. So if they've had previous head and neck treatment or breast treatment that encompass the supraclavicular fossa, please remember to do their thyroid function test. If they're on dexamethasone or steroids for a period of time for their side effects or cancer, need to rule out diabetes. If they are on androgen deprivation therapy, anemia, cardiovascular disease, so cardiac dysfunction needs to be ruled out, and just a general screen for fatigue. Physical activity, there's various advices out there, but essentially it really should be tailored. This is based on some ESCO guideline where a patient should be encouraged to do 150 to 300 minutes of moderate intensity over a week, 2 to 3 sessions of strength and resistance training. So I tell my patients it's not just cardiac health, because, for example, androgen deprivation therapy can cause muscle weakness, so they need to focus on muscle strength as well and avoid prolonged sedentary behavior, even if they go for short walks, rather than sitting down. And even if they're sitting down, move their legs. So it's just to give advice and tailor it to what our patients could do. And my strategy is, because I'm not a gym trainer or personal trainer, nor do I actually go to the gym a lot, but I refer them to trained personal or exercise specialists. There are supervised exercise programs. So Life Now Cancer Council is a free 12-week program. Go on the website, Google Cancer Council Life Now. It will take the patients through the website. There's yoga, Pilates, gym, and it's catered. Edith Cowan University have a research exercise institute for prostate cancer patient. And I think that the Breast Cancer Foundation also have the specific exercise programs for women. And really, cancer survivor specific quit materials, setting short and long-term goals. So I tell my patients to focus on the short wins, small wins, rather than big wins. Wearing a Fitbit, encouraging social support. So I have lots of patients now that has got together and form a group, especially in Midland, because there's no such thing before, and they really enjoy it. And identify the cause of barrier for exercise. Is it peripheral neuropathy? Is it pain? And often you'll find that it's because of pain where the patient said that I can't walk or can't move. Then really pain management, hydrotherapy, finding an exercise that could help. Radiation skin reactions, dermatitis, you might see this often in the community as well. Patients might be afraid that it's infected or inflamed. It occurs gradually during radiation. So if the patient had 1 or 2 days of radiotherapy, we do not expect a significant skin reaction. If that has occurred, we need to look into why that has happened, and you need to consider if there is an intercurrent infection. So I certainly had patient where I'm treating the leg. Within a week, there was generalized erythema. Of course, went to emergency, thought that it was radiation, but it was not. It was a streptococcal infection, cellulitis. Things like this needs to be thought of. Generally, the skin reactions start week 2, 3 onwards, and it builds up gradually from a faint to a more bright erythema. Ulceration and blistering can happen if we are treating the skin or chest wall or breast. Skin reactions are not common if we're treating prostate cancer, for example. But the late skin changes can be also a late side effect where there is a skin change, the change in the skin appearance. You'll see that your patients will have skin radiation, they have more pigmentation, either darker or lighter, fibrosis, atrophy, and chronic ulceration where the skin reactions doesn't heal. This is not common. It happens if the patient's immunosuppressed. Certain sites are more at risk, such as lower limbs or the scalp. If the patient has had radiation before and I'm treating that area again, then yes, they are at a higher risk of chronic ulceration. But other risk factors are connective tissue disorders. So patients with autoimmune disease like SLE, they tend to have a worse cosmetic outcome, for example, after breast radiation. Smoking, concurrent chemotherapy, skin reactions tend to be more marked around the skin fold as well. So around the axilla or in the inframammary area, the buttocks, as well as the groin. And of course, the more we give, the more skin reaction there would be. Generally, when you see these patients, need to avoid irritating it further, avoid trauma, avoid scratching, adhesives, waxing, perfume, talc. You may see your patients being given a cream called Strata XRT. Strata XRT is a silicone gel. They marketed themselves with normal sorbol cream. It is an expensive tube, and there's various efficacy. If the patient can afford it, I generally recommend it. But otherwise, normal moisturizer will do. And if there are skin ulceration or blistering, then we will look for dressings for that. And obviously, we manage the symptoms as they appear. And generally, as a radiation oncologist, I try my best to manage this the best we can in our clinic, together with the GP. In thoracic radiation, the common side effects involve the lung and esophageal inflammation. We will do a baseline pulmonary function test to decide whether or not the patient is suitable for curative intent radiotherapy treatment. But if they have underlying interstitial lung disease, we are generally very reluctant to give high doses of radiotherapy due to the high risk of pneumonitis. But the other side effects is that we know that patients will live for a very long time from their lung cancer treatment. They're at risk of developing cardiac complications as well down the track. And it is possible. I have, patients stage 3, stage 4 now who are living 5 years beyond their diagnosis. So it's important to consider cardiac health in these patients. A little bit about radiation pneumonitis. What is it? It's inflammation / sunburn of the lungs. The typical onset is 4 to 6 weeks, but can occur up to 6 months after radiotherapy treatment. Very unusual for it to occur during radiation. Related to the dose, the volume of lung treated. So if we're treating a large volume of lung, then clearly these patients will be at a higher risk. And the use of concurrent immunotherapy or chemotherapy enhances their risk as well. Typically present like a flu-like symptom or chest infection. So by the time they come to you, they've completed treatment. So you might think that this is a chest infection, but it's not, because they've completed their treatment. You need to think about possible radiation pneumonitis. Call us if you're unsure. Chest X-ray, it's very difficult to pick it up unless the changes are florid. I do a high resolution CT chest to correlate the CT findings with the radiation plan, because radiation pneumonitis will occur in the field of radiotherapy. If it's outside, it's infection. If you are very suspicious, you can do a CTPA to rule out a PE. And the management of this, depending on how symptomatic they are, but usually tapering dose of prednisone. And if they're problematic, I refer them to a respiratory physician. They might need bronchoscopy to rule out intercurrent illnesses. But if it's severe, which occurs about 5 to 10% of the time, where they're dropping their oxygen levels, they're tachypnic, these patients need to go to hospital. They're at risk of developing respiratory failure. Death from radiation pneumonitis can happen. So patient education, I tell my patients to recognize when they are going downhill, and I try to encourage them to call me as much as possible, but I find that patients don't often call us. They usually present to primary setting or hospital. Avoiding smoking is very important as well. In terms of pelvic radiation, the third common site, prostate, rectum, cervix, they may develop radiation enteritis, cystitis, side effects that can impact on the sexual health in the short and long term. And in the long term, pelvic insufficiency fracture or lymphedema. Now, pelvic insufficiency fracture is very uncommon. More common if I'm treating rectal cancer. The literature reports about 5 to 10%. If they occur, they may be painless, and it's something that we see on our CT scans as part of surveillance. But if they develop pain, it's conservative management with pain management and physiotherapy. But radiation proctitis is also very common. You might see this in your setting because it can happen when we treat rectal cancer, can happen when we treat prostate, cervical cancer, can occur during or shortly after radiotherapy, can also follow on from the acute phase or develop 3 months after radiation. The median presentation of late proctitis is actually 8 to 12 months after treatment, but can continue to happen beyond then. So that's why I follow my patients up for a long time to make sure that I don't miss it. And again, the general risk factors, treatment volume, treatment dose. Some patients are inherently more susceptible to radiotherapy toxicity, but other conditions such as inflammatory bowel disease, HIV, increases their risk of pelvic side effects. The symptoms, very bothersome. Diarrhea, fecal urgency, mucus discharge, bleeding, anorectal dysfunction. We have to manage the symptoms based on what the symptoms are, with either dietary modification, analgesia, pelvic floor exercises, counseling. If it is severe, endoscopic management, Botox injection may be necessary. Usually, the surgeons would try and do a sigmoidoscopy to make sure that it's not a cancer recurring. I would say that I biopsy with caution, because in the area of radiation, there's poor healing. Any invasive procedure can risk fistulation. Now, in terms of sexual health and fertility, I don't have a slide for that, but I just want to again emphasize that for both male and young females, do not hesitate to ask how is their sex life. Often patients are shy to talk about it. For female patients, vaginal dryness, atrophy, stenosis can be a real problem. Early menopausal symptoms can happen as well. Vaginal dilators, we talk about that. After they complete their pelvic radiation, we prescribe vaginal moisturizers. But if you are stuck, you either refer them to the early menopausal clinic at King Eddie's. They are very useful. And in men, again, penile rehabilitation with tadalafil or Viagra. If it doesn't work, there are sexual health clinics out there. There are not many in the public setting. There are a few in the private setting. Body image is often a big issue, asymmetry of the breast after treatment, stoma, vaginal stenosis, patients feel uncomfortable having sex. Counseling, very important. Patients might feel that they don't need it. I would highly encourage it. Now, in terms of useful resources for myself, I turn to evq.org.au. This is free resource for everyone. If you're not sure about the side effects or dosing for your ADT or treatment doses, there are patient resources there as well. So if your patient wants to know more about the side effects of radiation and you don't know where to guide them, direct them to this website. It's categorized based on treatment types, and there are patient resources on this website. Call the oncologist involved to discuss an early referral back to them, because I know that some of my colleagues, because their follow-up clinics are very full, we all tend to discharge early now to the primary care setting, but we are very happy to hear back if there are symptoms that you are worried about. For specific tumor types, Prostate Cancer Foundation, Breast Cancer Foundation, they have website, nurses, and support group. But there are clinical nurse coordinators in major treating centers that you could reach out to. In Midland, Fiona Stanley and Sir Charles Gardner Hospital. Often when patients are diagnosed, the clinical nurse coordinators are involved at the beginning and would have given their numbers. So even if you don't have those numbers, your patients may have the contacts already. But other than that, I find Cancer Council great. Their funding are being decreased, unfortunately, but they still do their best they can. Live now via website, I direct my patients there, or encourage your patients to call this free hotline number 131120, or ECU. That's also free for patients for prostate cancer. You can direct them for exercise, especially if they're on androgen deprivation therapy. That ends my talk.
Eve, I hate to interrupt. Eve, I just it's 7:50. I was just going to give you a heads up.
I'm done.
Well, that is absolute perfect timing. Let me just turn my. I will turn my video off so we can concentrate on you. But can you hear me all right?
I can hear you.
If that's okay, I'll just go through some questions from our participants. Thank you very much for that talk. It was fascinating. We know so little about these amazing topics, and I'm sure there'll be quite a few questions.
Sure.
I'm getting a comment from Alex, IT guy, that you can't hear me, but can you hear me?
Can
I have
hear
a few
you.
thumbs up from anybody?
I'm not sure if the participant, but I can hear you, Louisa.
Oh, I'm getting some thumbs up from the participants, lots of them. Great. So thank you. All right, so let's have a look at the questions. Great. No questions there at the moment from our participants. If anybody has anything, if they'd like to just put it in the Q&A bit, or if you're having trouble with that, you could put it in the chat. I had a couple of basic questions to kick us off, if that's okay, and they're probably very low level. Back at the beginning, when we talked about Mr. EB case, in his case discussion of his lung cancer, when you said he tolerated treatment well, does that mean basically no side effects, or he's just managing the side effects well and he does still need a lot of help, or in fact he's had none?
So the main side effect is a little bit of fatigue for him, which didn't stop him from doing his daily activities. And there were no respiratory complications. There were no esophagitis. There were no skin reaction. 3 months down the track, he may have an intermittent dry cough here and there, but it doesn't bother him. His repeated CT chest shows expected radiation-related changes, which may account for that. Usually this cough, if it starts, it might be permanent, but could also resolve with time. So it depends on how it evolves. But at the moment, 3 to 4 months down the track, when I use the word tolerated means that there is mild fatigue, some intermittent cough, but doesn't stop the patient from doing and enjoying their life.
And that's excellent, isn't it? So that's an amazing response for him. And
Louisa, that's
obviously
the goal.
that was,
that's the goal. It's impossible not to get any side effects, is what I tell my patient. You often hear patients say that I have no side effects. I often hear that. But if I really hone in and ask, the more specific questions, how much are you peeing at night? 2 to 3 times. Is it slower? Yep, it's a little bit slower. So if you ask, do you have any side effects? They will say, no, I have no side effects. But if you hone in and ask the specific questions, they are going to be, patient will report some minor side effects that you can identify, but often from their perspective, they don't view it as
excellent,
excessive. Correct? Yeah.
Great. That's so excellent. Now, there are a few questions up now. I think something was problematic with our actual chat system. So I hope we don't run out of time, but there's some great questions there. So I've got one that says, do you use topical steroids for local reactions from radiation, especially for breast cancer patients?
So I think Shahita, I can see the Q&A questions too. So there was trials looking at the regular use of topical steroids in breast cancer patients, and they found that actually the data supporting any reduction in skin reaction is very weak. In fact, prolonged steroid use could thin the skin out. So we don't use it regularly, but I use it if the patient have folliculitis, if it's very itchy. I use it PRN to relieve the itch together with loratadine. But other than that, I don't use it on a regular basis. Not for desquamation. For desquamation, I use dressings, the Strata XRT. After they finish treatment, I use a cream that has zinc in it. Typically Flamazine or hydrogel type ointments are very soothing.
And they're good because they're easily accessible to patients. Yes. And things too, and those aren't high cost. So that's great. Ingrid has got a question about cardiac toxicity with breast cancer radiotherapy. She had a patient very concerned about it. Is that common?
It is a well-established late complication from especially left-sided breast radiotherapy. I would reassure your patient to say that she would have been treated with a deep inspirational breath hold technique. That's the standard of care, where we will reduce the dose to the heart as much as possible, but the incidence is less than 5%. However, in young patients that has completed breast treatment or older patients, yes, as part of their breast cancer survivorship, they are often referred now to a cardiac oncologist to make sure that we monitor their cardiac health. Not all oncologists do that. So again, it's that counseling for your patient. It's not common. Please reassure them the incidence of any serious late cardiac complications are less than 5%. We try and reduce that risk by reducing their other cardiovascular risk factors, quitting smoking, exercising, healthy diet, regular check of cholesterol, hypertension, and blood sugar levels.
Yeah, okay. A question from Sadia. When post-radiation, how often do the oncologists, do they see them again? You know, how often? Is it surveillance then, or is it a set period, or?
It's very variable, oncologist to oncologist. There is a set surveillance strategy guideline for follow-up for all patients who has completed treatment. Generally, when a patient completed cancer treatment, the oncologist or specialist team, be it surgery or medical oncologist, would see a patient every few months for the first 2 years, purely because for the first 2 years, there is a lot of anxiety post-treatment, adjustment into normality, recognizing the side effects that are still there and managing it, and also to try and identify recurrence. If the cancer is to recur, the recurrences are often in the first 2 years, and then they taper off. So after 2 years, we generally stretch it out to every 6 months to a year. If I'm sharing the follow-up with a medical oncologist, we alternate that follow-up to try and minimize specialist appointments. Every oncology is different. So if their follow-up clinics are busy, you'll find that a lot of well-established, especially radiation oncologists, would discharge their patients into the community early. I would say that if you are unsure about what to do, I would send this oncologist a letter to make sure that they communicate with you what the appropriate surveillance strategy is. Normally they would, and they should. How often should GP follow up the patient? I guess for myself, I would, as soon as the patient finished treatment, I always advise my patient to go and see you guys, their GPs, because I find that GPs in the primary setting often don't get that full update, either from a delay in communication. Sometimes they are admitted and the GPs are not aware of it. So I said to my patients, please touch base with your GP, keep them updated with where you are at now, review the medications. Do you need to still be on this or that? Do a routine health check. And other than that, every 6 months to a year for a general health check, unless specified.
That's great. And we, as GPs, on behalf of everybody, we certainly appreciate that communication and that, cross-sharing of our patients. That'll be excellent. I think we've got time for just a very quick question from Shahitha. Now, I just there's probably a different part to this, because she talks about here, that a person post breast reconstruction had recurrent erythema over the reconstructed skin, requiring antibiotics through the surgeon. And it's sounding more like a post-surgical infection rather than the cancer or the cancer treatment. So I'm not really quite sure whether it's being asked because if that's a common side effect, surgical site infection. And I don't know if that's something that you wanted to address, or indeed if that's the actual question.
So it is very challenging, obviously, without understanding the full history of this patient. If there is recurrent erythema along the skin, sometimes lymphedema could cause that, because it stretches the skin and gives that area of lymphedema. So massage and moisturize. But if there's recurrent skin change, I really worry that, you need to a skin recurrence, for example. But if she's already seeing the breast surgeon regularly, then I'm sure the breast surgeon would think about this. I would think about this. Yeah. But from a GP setting, this is very specialist care. This is very specialist care. I would refer it back to the treating surgeon as much as you can, because it's until the surgeon communicates that this is nothing to worry about.
Great. Thank you. Given we're just after 8 o'clock, I'll probably hold the questions there. On behalf of all the attendees and the Cancer Council, Dr. Tiong, I'd like to thank you so much for such a fascinating and very informative presentation tonight. And I'd like to remind everyone if they could possibly do their online survey to help us with our further education. And again, thank you all for attending. I look forward to seeing you at the next seminar. And Eve, thank you so much again for a great evening.
Thank you, guys.
Take care, everybody.
You can reach out to me anytime. Thank you.
Thank you so much, Eve.
Thank you.